Hello and welcome back. So this is a really short overview on the Mayo Criteria used in endometrial cancer. We'll start with the clinical scenario. We have a 56-year-old with a past medical history significant for obesity. She had an endometrial biopsy with grade 1 endometrial cancer, and she's scheduled to undergo a total laparoscopic hysterectomy, bilateral salpingo-oophorectomy, and a sentinel lymph node dissection. In the operating room, you have injected your ICG, you're operating, you've dissected out the retroperitoneum and opened your spaces, and you turn on the Firefly and you note that she doesn't map on either side. And so you're asking yourself, what do I do next? Well, in order to answer that question, I think it's valuable to go back and look at the literature and note, why do we do a lymph node dissection in endometrial cancer? And so you'll see this chart to the right. This is in one of the very first papers that discussed surgical staging for endometrial cancer, as we used to do clinical staging. And as you can see here, surgical staging really improves the proportion of patients who were surviving. So proportion of patients surviving, we have surgically staged patients. Even surgically stage 3 patients better than a clinically stage 1 patient. And so we can look back at the literature and note that not only based on this paper, but there are several other papers that looked at the value of a lymph node dissection and whether or not it adds to a survival benefit. And we have not seen a survival benefit in performing a lymphadenectomy in endometrial cancer. However, we know that comprehensive surgical staging leads to better prognostic implications and better adjuvant treatment. GOG 33 was another sentinel paper. Do you see what I did there? With looking at the spread of endometrial cancer, looking at it surgically. And so this first table we'll focus on here because it's talking about pelvic node mets, and this is aortic node mets, but we'll focus here because we're mainly talking about a pelvic lymph node dissection. And you can see that the depth of invasions here and the grade is here, and the incidence of pelvic lymph node metastases are noted here. And so when the cancer is confined to the endometrium, there's a very low risk of pelvic lymph node mets. And this is very important for what will come next as we talk about Mayo criteria. And as you go deeper, as you increase the depth of invasion, you increase the risk of lymph node metastases, and same with grade as well. And so back to our question, what do you do next? So one thing you can do is you can perform a full pelvic lymph node dissection. However, you may be asking, why wouldn't we do this? And you know that there are risks to performing a full lymph node dissection. This increases your OR time, and we know that increasing OR time, there's data to show that this increases risk of complication in laparoscopic as well as open surgery. There's an increased risk of blood loss. We're opening the retroperitoneum and we're dissecting around critical structures. Increased morbidity, and then importantly, especially for patients, this increased risk of lymphedema and lymphocyte formation with the removal of an increasing removal of lymph nodes increases the incidence of lymphedema or lymphocyte formation. So your second option would be, I didn't tell you the second option yet, but the question is there a criteria to determine if lymph node dissection can be omitted based on the patient's risk of lymph node metastases? So we've kind of set you up with one early paper with some possible criteria to determine, could a patient be at a low enough risk to maybe omit the lymph node dissection? And that's where Mayo criteria comes in. So this was an observational study of 328 patients, and they looked at these patient characteristics, and they observed that patients were low risk for nodal mets if their tumors were grade 1 or grade 2 endometrial cancer, myometrial invasion was less than 50%, tumor size was less than 2 centimeters, and they had no obvious metastatic disease in the abdomen. Patients who met these criteria, not one patient had positive lymph node mets. Any of the patients who met one of these criteria, or I guess did not meet one of these criteria, so either grade 3, greater than 50%, greater than 2 centimeter disease, these were considered high risk for nodal involvement. Since the Mayo Criteria was published, it has since been validated by several studies. So when you're in the operating room, you can use this criteria to assist you in deciding on a full pelvic lymph node dissection. There are times where you don't know the grade going into a case. The study, when it was done at Mayo, it did send the uterus for frozen, with the caveat that the Mayo Clinic's pathology department is excellent at reading frozen uterine specimens, and that isn't the case across the board. So you do just need to be cautious and know the limits of your institution. It's not always reliable. That's why it is also nice to know going into the surgery what the grade is. And then also just of note, this is completely different than adjuvant treatment. And I think residents oftentimes will get this confused with GOG 99 or Portec. So know that this criteria will help you with intraoperative or even maybe preoperative decisions, but does not have anything to do with adjuvant treatment. And we can go over that in another lecture. But if you were thinking about adjuvant treatment and you're trying to think, well, how are we going to know how to treat this patient without knowing their nodal status, we can look to the Portec studies, because those studies did not actually include lymphadenectomies. So more on that in another lecture, but just know that the option is there. If you want to look at the full Mayo Criteria paper, this is it right here. And that is it. So subscribe if you like these videos and you want to learn more. I would love your feedback in the comments, and let me know what you want to learn about. Have a great day.